Welcome, everyone, and good morning. My name is Janae Coley, and the Education Director for TCHAT. And thank you for inviting us this morning to provide this presentation for you on suicide prevention. We have Dr. Garza, who will be providing the presentation for you. She's an assistant professor of family medicine and psychiatry at UTRGV. She's a clinical psychologist and serves as a behavioral health consultant for the UTRGV School of Medicine Texas Child Health Access Through Telemedicine Program, TCHAT, and is a research co-principal investigator for the UTRGV Texas Child Health Care Consortium research projects on child trauma, depression, and suicide. So I will turn it over to you, Dr. Garza.
Thank you. It's good to be here again. I was trying to remember when we last had a presentation with Cal Allen, so I'm going to do my best. I know a lot of people are teaching right now, and so a lot of you are probably going to be watching this later. And so please know I'm going to be sharing my email because I'm aware of that. So always feel free to reach out later and email me if you have any questions or if you want to even meet for a brief chat about what I'm talking about today. I am going to share the presentation now. I wanted to do a little gauge on what we want to focus on today because last time there were questions after, and I remember thinking I wish I had saved more time for talking. So it looks like that might be what we do today. So I'm going to review some things that we covered last time, talk about other suicide prevention strategies that we didn't really go over the first time around. And then I'm going to touch base with you all if anyone has any thoughts or questions that we'd like to talk about. And then we'll go into an example of a brief intervention that we do. So give me one sec. Okay. So today we're going to be focusing on suicide prevention. Last time we met, we went over assessment and treatment of self-injury specifically and how that related to suicide. So today we're going to focus more on suicide. The two are very similar when it comes to what we do in the room. And a lot of times it's because they often co-occur. So I'm gonna just put this up just for a quick review of what we did last time. So we talked a lot about self-harm, common co-occurring reasons and problems that come with it, such as suicidal ideation, assessing for self-injury and determining risk, safety planning and strategies for coping with any suicide or self-harm behaviors, your specific role in the school district, and then resources. And we talked about examples that teachers tend to encounter compared to maybe like a mental health profession. So today, so these were things that I think I just said all this. So today, I'm going to try to keep it simple with just 4 main things that we're going to do. I'm going to review some major initiatives that suicide prevention involves from different levels or systemic levels that we address it. And then I'm also going to review just very clear the 5 action steps, it's called, to help someone who's having thoughts of suicide. These action steps are for anybody. And so I think it would be helpful just to review that. A lot of people are wary if they're not a counselor, maybe they'll say the wrong thing or do the wrong thing. And so there are a lot of materials and like recommendations for anyone. Unfortunately, a lot of kids help kids. And so we have to think about that too, making these type of guidance plans. And my hope today, I didn't get to last time. A lot of people, unless they've been in the unfortunate circumstance of being a parent or they were a child themselves who had gone through brief intervention and treatment, or maybe they were the identified trusted adult. So maybe they weren't the parent, but they were like the trusted teacher, or even if it was like another family member or a friend. Unless that happened with you, a lot of teachers don't get to see it in action. They don't get, maybe you walk the kid to the nurse's office, or maybe the crisis team takes over, right? And there's like a handoff. And so I think can be like this mystery of what happens behind that closed door. And so today I was hoping to at least show a little role play. If anyone here on the call is willing to play the child or the teenager who's going through self-harm and ideation. My goal for this is not to put someone on the spotlight, but more for me to demonstrate how I navigate the questions and just how this really is just a conversation for next steps. And if we have nobody today who's willing to do that with me, we could also just focus a lot of today on questions, answers, thoughts, worries after I go through the material. If you are comfortable, please message me or just let me know when I ask. So it would be really helpful. Okay. So we are here. So I have this schools part highlighted. And I'm going to be sharing this presentation at the end of this hour. I'll share it in our own chat, and then I'll send it along so that all the teachers who watch this later also have the presentation. I'm sharing it also because there are a lot of resources and links in it. So that will help me just make sure that everyone gets what I'm talking about. So don't feel like you have to be like taking notes right now or finding these websites. They'll be shared with you at the end of the hour. Okay, so to start off, the Suicide Prevention Resource Center is a go-to place, or the SPRC is a go-to place where there are a lot of resources organized according to the setting where you work. And so one of the reasons I have this as our first slide is because all of us, no matter where you are, all of us have a role to play in suicide prevention. And it is such a huge endeavor for one of the leading causes of death here in our country. And so being familiar with what you can do within the setting you're in personally is very important to me, because it could feel overwhelming. It could feel like this is such a huge problem, the scope of it, the amount of people that it affects, how pervasive it is, how much it like affects different elements of someone's life. So much, right? So one of the ways I cope with that is I try to narrow down, okay, wait, where am I? What can I do? And so this is a great website for teachers, because if you click that schools link, it'll give you resources and information that's specific for school settings. And I think it'll even like break it down by, are you administrator? Are you a school counselor? Are you a teacher? So I really encourage you to explore this for Calallen, because you might see different initiatives on there that maybe Calallen can incorporate into their school life. Okay, so where are we at now? There has been a lot of work over the past 50 years or so on suicide, what it is, what are related problems associated with it, such as depression, trauma, anxiety. And so knowing what it is and then what to do about it has been basically like the past 50 years of research. We do know, for example, that suicide, specifically teen suicide, is outrageously high. We are living in a time where many people, at least in millennial generation and younger, at least know of someone who has completed suicide. That's how common it has become. And if they don't know someone who has completed it, they know someone who goes through ideation. So the frequency of this problem is so high that it continues to be a leading cause of death. I think at times it's between 1 and 2. So this is an urgent public health issue, and researchers have been funded by federal and state entities to figure out what to do, just like any other public health issue. So NIMH has been a big part of it. Our own state of Texas, the research studies that Ms. Coley mentioned just now, are funded by the state because of how high how high the problem is, or how common it becomes in mental health care. These research studies are now at a time where we're focusing on what can help. So we've learned a lot about identifying it, asking the right questions to help determine risk and what we should do depending on the risk. We've got a lot of toolkits for different types of professionals and parents and caregivers. And so now we're continuing to build on actually informing the practice itself. So when someone has already been able to endorse their suicidality and they're seeking care, research is now looking into what programs in the community or what therapy can do, so that it is structured in a way that it's continuously efficacious. So we know that therapy helps, right? We know, even if a therapist doesn't have like a go-to manual of what to talk about every day, we know having a therapeutic environment and a supportive place that you can go to on a regular basis, we know that helps. But we want to know more. We want to know what are the exact things that a therapist can do or say when they say it and how they say it. Because the more specific we can get, we don't need to manualize everything, but we can actually pinpoint what interventions are actually working for the majority of people. And when they don't work, what do we do next? So that's where research is now, I would say. So when I tried to summarize, I didn't want to overwhelm. So these words right here are my attempt to summarize my scope, and what I do as a mental health professional. So when I think about my work as a psychologist, as a counselor, as a researcher, these are things that I feel that are commonly happening in my job. And I think it's helpful to see it like this because any mental health counselor should be focusing on these top 4. A researcher or someone who works in the community, add that last one. And so I'm going to review these because I think it also helps review what we went over last time. Because in our last presentation, we talked a lot about how the role of the teacher is also to help identify that first bullet point there. And We talked a little bit about after you identify what happens, what kind of services or brief interventions and care does the child get. So just to walk through these, this is what we would call the treatment intervention or strategies. We're going to look at the arms for them here soon. So in identification, there are three main goals. To screen, so you ask as little as you need to. You're trying not to get someone through an hour-long interview because it's really stressful to be talking about this, right? And for a lot of people, this might be the very first time they talk about their suicidal thoughts. So there might be a lot of emotions in the room, especially if they're a child or a teenager. They're holding the reactions that they might anticipate of their loved ones. And so screening tends to be very short. It tends to aim towards brief, so anything between 5 and 10 minutes. I know it might seem like, what? You can do that in such a short amount of time? Yes. If you accept that you're going to say the word suicide, you're going to say very clearly, have you been thinking about suicide? Do you have a plan to kill yourself? Have you tried to kill yourself in the past? A lot of counselors have to learn to get comfortable with just saying it. It is a milestone in their learning and development. And when we can clearly say it like that, we're also validating to the other person and signaling to them that it's okay. We can talk about it right here, and I'm not gonna bring my emotions into the room. I'm here to help. And so screening does tend to go by pretty quickly when you don't walk around the issue. Assessment tends to be a little longer, or a lot longer. So assessment will happen, maybe it could happen in a school setting if you have professional counselors there, but typically in schools, there's more screening. Assessment tends to happen in ER settings, at a mental health clinic, maybe even at a primary care clinic that has more comprehensive or integrated services. And then in general, a big, like the backbone of identification is creating a culture or an environment that is destigmatizing so that the person can actually endorse what they're going through. You can have all these great screeners and assessment procedures, but if you've got an environment where the person doesn't feel safe or they don't feel like they can be open, they're not going to say yes to it. One of the questions that came up during our last presentation was, what happens, when a parent is worried? So one reason that a child may not bring up the thoughts that they're having to their parent is because they don't want to worry their parent. Very often for teenagers and children who go through this, they have feelings of being a burden or feeling like guilty for their condition that they're going through. And so I had recommended, just like a counselor, when a parent is being there for their kid and their kid is talking to them about what's going on, one of the skills of a parent, a caregiver, a teacher, a counselor, one of the skills is to hold your reaction, right? None of us want to hear a child talking about this. And so it's going to be devastating. I don't care how many kids I hear talk about this, it's always devastating. And so the skill is being able to hold that and put it to the side for the kid, because the kid is already probably worried about whether or not how they're going to affect you. And I know it sounds kind of counterintuitive, right? To not show all your emotion. But the thing is, one of the things that we're showing it's an opportunity to show them that they can trust us, that we're able to keep it together, and we're able to prioritize them. And it doesn't mean that you have to be like a zombie, and not show anything. I think it's okay to show concern and maybe fear of what's happening. But it's also an opportunity to model emotion regulation. So it's an opportunity to show the child that even when you're faced with something that's really scary and that doesn't have a clear answer, and there's just a lot of unknown, we're still here for them, right? And we're going to be here all along the way. And so that's one of the first things that a caregiver has to do. And when they do that, they're creating an environment that is open, and that is ready to be supportive. So I like to start with that example because it does start with you, in creating that culture and creating that vibe, like kids say, around us. And eventually it becomes something that's throughout the whole school, that's throughout the whole clinic, that's in our public settings, that's at our community fairs. And then that's basically in any social interaction that we engage in, wherever we are. That's the goal. We want our kids to feel taken care of, right? No matter where they are. So identification is very often the first step, but before that, that's why we're here, right? So what happens even before that? And so prediction involves knowing the warning signs, knowing the risk factors, and the common co-occurring problems. And I can go through those again if you all want to, because we had gone over those last time as well. So knowing what to look out for, knowing if you see something that is concerning, is that a thing? Like, is that something that we're gonna address? Because unfortunately, there are also many children that never come to us, for as much as we might try to build this environment that is supportive and welcoming and open and destigmatizing. For as much as we might try, it's the ones that don't seek help, the ones that don't talk about it, those are the ones that are most at risk. So being able to see it, being able to identify it even when they don't come to you, that is really why we're here. So starting the conversation. Brief interventions are going to happen whenever someone encounters any sort of care. And so one of the reasons I wanted to role play it today is to show that it's something that you can do. A lot of teenagers actually get skilled in these kind of interventions, because very often kids will first tell their friend, and maybe they only feel comfortable telling that friend for a little while. And that friend has to learn that, yeah, I'm here to talk to them, but that friend, that teenager, that kid, has the responsibility almost of figuring out how to bring in an adult to the situation. I've worked with kids who have lost friends because they went and sought help from an adult, and it didn't go well. And that kid that was having the thoughts maybe just ended up in the ER with no follow-up and was mad at that friend of theirs that they told. And so a big part, that's why I have follow-up on there, a big part of our brief interventions, if you're going to be the one to engage in the screening or to put them in contact with someone who is and get them the care they need, very often when we hear the risk of suicide going up after care is provided, a lot of that is because there's no follow-up. So basically, like, they just got hospitalized for 72-hour hold, went home, didn't get a counselor, didn't get any follow-up supportive services. And unfortunately, that is related to accessibility. So do they have the insurance? Do they have the family who's available to be taking them? Do they have in-school services that makes it easier? Follow-up is key. And that really contributes to their whole healthcare experience and their inclination to go seek help. If a child feels like, oh, well, I'm not going to talk about it because all that's going to happen is I'm going to go to the ER, well, that kind of makes sense why they would be deterred, right? And then so collaborative care is a big part of it for that follow-up as well. So more and more primary care services, like pediatricians, are becoming involved in being a part of this team. The more adults a child has to be able to vocalize what they're going through, and then the more those adults are working together, we can provide the care that the child needs. The other part to this is the public and community health. And so that's actually what I'm going to share today. Give me one sec. Oh, I'm sharing full screen. So, sorry, one sec, my computer's thinking. Okay. So this is the national strategy. It was published this year. And I encourage you to look at it if you're trying to figure out where you are in your role. It breaks down the directions into 4 main ones. So community-based, treatment, research, and health equity. So kind of like what I was saying about just accessibility. And it complements the federal action plan, which is right here. And the federal action plan really summarizes all the things our federal government is doing. I think they have like 200 or some actions that they're doing. So for example, the 988 number that is funded and paid for completely by our federal government, right? And there are many other things for veterans, for specific communities that are more affected by suicide, such as our Native communities, our LGBTQ communities, who have a disproportionate increase in completed suicides. And so let me just show, I'm going to click this so that you can see it. And so each one has different goals associated with it. So for communities, kind of like what I was saying about creating that culture, there are many components to what a community does to support the child. And just to show you what this looks like. Oh, it's thinking. So it's a pretty long document. Let me just scroll so you can see. Here we go. Teachers, I think, are very often grouped into community-based work because when community programs or public health programs are created, they very often can be school-based. And so having those collaborations, those partnerships like right now, what we're doing right now is considered suicide prevention. So we're actually goal 1 right here. Being able, let's say somebody goes and finds that schools category today and they see some kind of thing that they can implement at Cal Allen. I don't care if it's just a handout that someone posts on the hallway or it's like a free training that someone finds and shares with the school. That's something called upstream. So anything that you do to increase prevention in your community, in your setting. There's also things in communities to help protect, so not having access to lethal means in the community. That can mean anything from gun control to being aware of where where children are and what they're exposed to. And then another thing that we do in the community is after a suicide, we see what's called a cluster, which is an increase in completed suicides of people that knew the first completion. And so it does affect the community. It increases a sense of hopelessness. And so there are strategies that we used for postvention in order to prevent the after results of it. And these are, I've held like talks in the school with kids, with teachers, with families. And a lot of that is just to immediately address the situation, a lot like a disaster response. And integration with, so I've been mentioning this one, the culture of the workplace and what we do. So when you see like community health fairs that are trying to normalize these topics and trying to have like a mental health fair or anything, when you see mental health is health, anything like that is trying to change the culture and destigmatize these topics because they are scary to talk about, but we talk about scary things all the time, right? And for some reason, this one is something we shy away from. And so trying to normalize that just because it's scary doesn't mean we don't talk about it. And so I can go on and spend a lot of time with these. So like a lot of the work I do is treatment and crisis services, especially gaps in care that we might experience in our community, and what we can do to try to meet those gaps. And then things like I was mentioning, how can research help improve how effective we are in our therapy. And a lot of health equity also have to it is basically access. So being able to have this free training, for example, being able for students and kids to be able to access any sort of suicide prevention services or resources. Let me go back to, here we go. So just with that, I'm going to show, all right, remind myself what I'm doing. So this is an example of a community public health initiative. So you'll see that there are a lot of free images that you can share online, a lot of brochures, a lot of materials that are free completely to use for commercial use. And that's one of the goals, right? To make it something that anyone and everyone can talk about. So this is one of the links on here of just free videos that you can share with students or your team and things you can do. So anytime you see publicly available information that can be shared and used, that's really part of the suicide prevention work. All right. So to review what we pretty much did last time. So what do I do? What do I do if I feel like I see something, like you might see a self-injury? You might have just been in your classroom during an office hour and a kid comes up and the student says, hey, this is what's going on with me, or this is what's happening with my friend. So knowing what to do, I really like this initiative. It's just 5 things to remember to do. Talk about it, ask it directly. Last time, I think I asked you all, so I'm gonna say this right now. Everyone is muted. Just take 5 seconds, 10 seconds to say this out loud. Right, no one's listening to you. So just say out loud right now, are you thinking about suicide? There are a lot of people who have never said those words out loud before. So say it out loud. Are you thinking about suicide? It's okay to be nervous to ask that. It's okay to feel like, oh, I don't know about it. We know that asking directly helps. So get comfortable doing it. If you're not comfortable, you can acknowledge that. I know it can be hard, right? So having a kid in front of you and trying to keep your cool and trying to be there for them and saying, hey, I know this might be hard to talk about. And you might be saying that for you too. I know this might be hard to talk about. I'm going to ask you something about it. Are you thinking about suicide? Right? So you could preface it like that too. And just being there after you ask that question. Don't just wait for a yes and then like send them to the principal's office. And so be there for them, listen to them after you ask that question. And we talked a little bit about what you say back. So using your ORs, and it'll be here in the presentation. So open-ended questions, affirmations, reflection, and summarizing. I hear you talking about when your dad died, you started to have these thoughts. And you're having these thoughts that sound like this. You're summarizing back without adding your opinion or your judgment on those thoughts. The next step, once you have that moment, let's get you safe. I'm thinking about what we can do to help you stay safe today. Sometimes I will specifically ask the person, like if I'm not sure yet, if they need immediate next steps, one of my favorite questions to ask is, do you feel like you need help staying safe today? You'd be surprised how many people, they seem like they're okay. And it seems like they'll be able to wait for a counseling appointment next week, right? And then you ask that question and they're like, actually, yeah, I don't know about today. And so I try to ask that question. Do you need help staying safe today? And if they say no, but it's very clear to you that they need something, it's okay to fall back on your responsibilities, right? Hey, as a teacher, as a mandated reporter, part of me working here, I need to make sure that we do what we can to keep you safe today. And then we connect them. So we always provide some kind of immediate thing. So I say, pull out your phone right now. Can you pull it out really quick? Can you bring up your notes app, or can you just call this number so it's saved on your phone real quick? They can text that number, they can call it, they can go on a computer and there's like an online chat for it. It's a great resource. And then, like I said, follow up. If you were the person that they endorsed to you, then you're the person to make sure they got that follow up. I'm going to put that responsibility out there. I wish I could say, yes, it is the responsibility of the care provider. It is the responsibility of the ER provider. It's the responsibility of the counselor. It's the responsibility of the parent. Yes, all that is true. But if you're the first person that they came to, knowing that follow-up tends to fall through because of equity and accessibility and whatever, follow up. Say, hey, I know it's been like a month since we talked. How's it going? Are you getting any help? Are you getting someone that you can meet with about it? Because if they tell you no, go back to number 2, number 3, right? Because it didn't happen. Okay, so just like there are resources for kids, for parents and teachers, or I should say, just because there are resources just for professionals, there are also resources for the kids, for the teens, and for the parents. And so I have some of my favorite resources up here, and I'm going to just show them real quick. Give me 1 sec. So this is the NAMI Texas chapter, and it has a bunch of great resources right here, which are links. And there is specifically a book I want to show, or I might have to click it. Sorry, give me 1 second. Yes. Exit on. Okay. So this is a website from the American Foundation for Suicide Prevention. And this is more for parents. And one of my favorite resources on here is actually this booklet at the end. The picture right here that links to it. And so it actually goes through even resources for schools right here. And it has a specific focus on what to do for a teenager or a kid who knows someone who died by suicide. And so it's going to go into self-care for the parent, knowing about suicide, knowing what happens afterwards, and being able to guide the parent or the caregiver or the trusted adult through these conversations and common questions that kids will ask after someone dies by suicide. It's very helpful and just another example of a suicide prevention program, right? There's also a whole section for the teenager themselves. Another really neat one, so there's how to help a friend, like I was talking about. So things that they can do in order to just literally talk about it. So I've opened these up when I've been meeting with a child who is going to therapy for themselves, but then this comes up and they want to know what they can do. They'll have an example of a conversation. Really great. There's a lot of stuff on here. If you know a child who's going through this, I encourage you to just click through all these. Some of them are more like interventions. So like things that they can actually practice, like coping strategies. And some of them are, I think there's even like a podcast on here. Really great go-to place. Grab this last one. This is one of my favorite free therapy courses online. I think it was released last year. DBT is one of the most commonly used therapies for suicidality, especially among adults. They're starting to adapt it more for teenagers and kids. It has 4 main domains of coping. And basically, someone can go through these modules. They could do one a day and learn 40 different coping strategies, right? I really love them because they're easy to understand. So they'll describe so this skill, for example, is observing an object. And it's just a mindfulness skill. And it'll explain it. It'll have a little video explaining the skill. It'll walk you through it, and it will have a little handout to help you practice it. And it will even have a little AI that knows that skill and will guide you through it. So like if you didn't want to read and you didn't want to watch that video, you could just have a chat with the AI and it will teach you. It'll ask you like pick an object around you, and it's actually pretty good. So I encourage you to click this if you also want to learn the examples of coping strategies that kids will learn in therapy. Let me go back here. Okay. All right, so let me go back to our goals today. So I'm going to share one last thing, and I think this will, I hope this shows. Sorry if this isn't pretty. So these are some of the most common reasons for self-injury and suicidality. These are reasons why people will start to feel depressed and hopeless and suicidal. And so when we look at this list, some of the things are more complex, I think, than others. So for example, childhood abuse. We know that trauma survivors have an increased risk of depression and thus suicidality. So what we do about trauma is going to be different than, say, learning a coping strategy of what to do when you're feeling like you have to punish yourself, Or let's say that your go-to way of coping with suicidal thoughts is cutting. So that's why having not just resources that educate the public about what suicide is, and what suicidal thoughts are, what depression is. There's also the other big part that actually my heart is going towards now is having coping strategies that are easily accessible and easy to learn, because someone usually may not learn the details of those coping strategies unless they're in therapy, right? So I'm a strong believer of also making those publicly available as a part of suicide prevention. And I know that having adults that know all the strategies may not be like possible, and we all have our own awesome coping strategies that we've created. But there are core ones, as you saw on that website. So being able to point to that for a child who's trying to learn more adaptive coping. Okay, let me go back to our. So I want to ask just now, after I reviewed all that, does anyone have any questions about everything I just brought up? Any questions about any of that?
Can you show us one more time how to get to that resource, that book on that NAMI Texas website?
Yeah, I can actually share it right now on the chat.
Thank you.
Mm-hmm. And it's going to be in this presentation too. It's one of the links on there. As you can see, I have a ridiculous amount of links on here, so I'm going to clean it up. Okay. So, anyone have any thoughts or anything they want to talk about for now? There's no silly questions.
Are are these steps like applicable to older children that are kind of like hyper aware of themselves and they kind of are like, well, I already know this and like I already know this and it's not helping.
Yeah,
Like
so like
teenagers.
treatment resistant almost.
Yeah.
Yeah, so there are a lot of people who experience suicidal ideation throughout their life for years. There are some people that experience it for a year or maybe just for a month, right? Like during a depressive episode. And so people who have experienced it for a very long time and who have tried to seek support and have gone through therapy, have maybe gone through like CBT, a cognitive behavioral therapy, might still live with those thoughts. And I think it's a good question because it kind of reminds me of trauma work. Sometimes, depending on the trauma, someone might still feel certain trauma symptoms, right? Like their body might still get really activated if they are reminded of something that happened to them. And so part of it is also trying to figure out acceptance and what you can still do about it, even if what you have tried hasn't worked. I do try to say to kids and teenagers that just try it. Just try it. I know this is a new corny coping strategy. I know. But whether it works or not is one thing. You communicating to your brain and to your body that you're trying new things, that you're not giving up and you're trying new things to see if they work, that's the true intervention. So not telling your depression that nothing works. So I do try to say that depression tends to be kind of black and white, right? Like, oh, if this doesn't work, then none of it works. If that therapy didn't work, then no therapy works. If that was a bad counselor, then all counselors are bad. Depression tends to do that. And so I do try to inform people who go through depression, like, hey, just so you know, that is a part of depression. Depression wants you to not have hope that things might change. And when you practice something new, you're showing your depression that you're still trying and that there is actually logically something that's going to help. It's just a matter of finding it. And you talking to me today is you showing me that you are trying. It can feel like this weird argument, like, or debate, but as long as you stay with the fact that they're talking to you and that is a sign that they're trying to get help, that's what matters to me the most. There is in therapy, when I was talking about like what research is trying to inform, there are types of therapy, like a directive therapy where we do a certain thing every time, and we already know what we're going to talk about. We already know the activity we're going to do or the coping strategy we're going to try. And then there's a non-directive therapy where the client leads. That we talk about what they feel they need to talk about that day. And for some people, non-directive therapy, especially people who have had negative healthcare experiences or treatments that haven't worked for them, non-directive therapy has lower dropout rates, especially among trauma patients. And so I think it's also something for the counselor to consider. How am I going to accommodate to someone who hasn't had the best healthcare experience? I am going to, I know we only have a few minutes, so I'm going to go to this again from our last. Give me one sec. I'm going to pull up. Sorry to flash your eyes with all this. There it is. All right, so this is what I didn't get to do with the role play. I'm so sorry. The time went by so fast. But I do want to just give an example real quick. And so say you have someone who comes to you or you see a cut, you have a reason to feel like they're hurting themselves, and you want to first ask anytime there is an idea that someone might be at risk. So whether they're engaging in substance abuse or self-injury or risky behaviors in general, it's always helpful to have this statement in mind. I know that some people who experience what you're going through, they think about hurting themselves on purpose without intending suicide. Have you ever hurt yourself on purpose without intending to end your life or attempt suicide? So that's pretty much how it sounds when someone is trying to ask about non-suicidal self-injury. And some people do think about completing suicide, and one of the ways that they avoid it is to self-harm. And so the way we work with people who are engaging in self-harm to prevent suicide is definitely, it's difficult, but we want to know at first, are they having thoughts of suicide while they're hurting themselves? And if they're having those thoughts of suicide, what do they sound like? Why do they feel they have those thoughts? Just to go through it really quick. I know, so we figure it out. Are they also having suicidal ideation? When was the first time you cut? When was the first time you hurt yourself? How long has it been going on? How often do you cut? What do you usually use when you hurt yourself? Has it changed? You said you started cutting yourself 2 years ago, about once a week. Is it about the same now? It's the frequency. What happens after you cut? What's your routine? Has it ever been so bad that it didn't stop bleeding or it got infected and you had to go get help? Aftercare. When you think about cutting or when you are cutting, do you know why? Do you know what you're reacting to? What does it do for you? So the reasons for why someone is reacting. Is it an impulse? Did something happen that day? Think of that list of reasons. And then the big question for next steps. Is this something that you would like to stop? Well, if I stop, I'm going to lose like my one coping strategy for dealing with my panic symptoms. Have you considered stopping? Yeah, I think about it all the time, but I don't think I can. let's maybe try to increase other coping strategies, other things you can do, and then we'll figure out stopping. I don't want to take away their only coping strategy, right? And I want to validate the reasons that they're bringing. And just starting that conversation like that. I did that in just a few minutes. But it does take longer, right, when someone's answering. This is something that I hope that one day everyone feels at least ready to do. So if you are going through this, or if you feel like you would like to talk about this more, please feel free to reach out to me. I am going to take a moment to upload this on our chat, so give me 1 sec. I have to close it out. Any questions before we go today? I'll type up. Okay. And just in case, I'm going to say it out loud. My email is cynthia.garza, the number 1 at utrgb.edu. Please feel free to email me if there's anything you want to talk about, or if you have any questions or just something to bring up. I'm always trying to make these presentations better, so if you guys have any recommendations, just let me know.